صباح النور دكتور.
Today we will discuss the lecture urology instead of yesterday. هاي محاضرتنا مع البارحة مالت الجراحة البولية، راح نقدم لكم إياها إن شاء الله اليوم. Today we will discuss the malignant tumor of the urinary bladder, CA bladder. Incidence, the male-female ratio is 3:1. In our country, the most common urological CA, one of the most common urological CA, it is the CA bladder. As you know, there is multiple causes or factors that increase the incidence of CA bladder in our country. The patient with smoker, pollution, exposure to dye material, or also there is a history in our country of bilharzia infection or schistosomiasis that increase the incidence of the CA bladder in our country. Actually, the male-female ratio is 3:1. CA bladder is the second most common cancer of the genital urinary tract. The average age and diagnosis is 65 years. At the time of diagnosis, approximately 85% of the CA bladder are localized to the bladder, and 15% have spread to regional lymph node or distant metastasis or distant sites. Risk factor for pathogenesis, it is cigarette smoking. The most important.
السلايد ما جاي يتحرك.
What?
السلايد ما يتحرك.
ليش؟ يتحرك يمين. اوكي تتحرك ولا لا؟ اوكي؟
لا دكتور بعد.
ما بتحرك ولا لا؟
لا.
هسه؟
لا دكتور.
ماشي. هسه تتحرك ولا لا شباب؟ اوكي؟
لا دكتور ما جاي يتحرك. اي دكتور هسه تحرك.
اوكي؟ اوكي اعيد. The male-female ratio is 3:1. CA bladder is the second most common cancer of the genital urinary tract. The average age at diagnosis is 65 years. At the time of diagnosis, approximately 85% of the CA bladder are localized to the bladder. 50% have spread to regional lymph node or distant metastasis. Risk factors and pathogens. Cigarette smoking. Smokers have 2 to 6-fold increase the risk of CA bladder than non-smokers. Smoking is a causative factor in up to 50% in men with causative agent as found beta-naphthalamine, which are secreted into the urine for smokers. Consider one of the worst products of urine or content of urine in smoker or heavy smoker male or patient, it is the naphthalamine. So when it comes in a question, what is the active factor in smoking that cause CA bladder? It is the beta naphthalamine. Okay. Occupational exposure. Occupational exposure. Patients who are exposed to organic chemicals as aromatic amine, aniline, dyes, beta naphthalamine, usually include people who work in chemical, dye, rubber, petroleum, leather, and printing industries are at increased risk. Cyclophosphamide, cyclophosphamide drug used for management of various malignant diseases has also increased the risk of CA bladder. So when one asks what is the chemical substance that increases the risk of CA bladder, it is the beta-naphthalamine. And when someone asks what is the drug or medical substance, a drug that used for management of other things and increase the risk of malignancy and in the bladder, it is the cyclophosphamide. Okay. Physical trauma to the urothelium. As I said previously, there is incidence of in our country, previous incidence of high incidence between people, especially in the southern of Iraq, especially the who is near the rivers Tigris and Euphrates and the marshes. A lot of patients infected by schistosomiasis previously. As you can ask your parents or grandfather. Previously, they said every Iraqi when get puberty or enter puberty, they should urinate blood or hematuria, get incidence of hematuria. This because of schistosomial infection. Okay, after that, the government get rid of this infection by different condition. Nowadays, it is a little bit present in our country, but the bad effect or previous effect of it on the old age people present till now. Why the schistosomiasis causes CA bladder? What is the mechanism? The mechanism, it is a physical trauma because the schistosomia put its eggs, and the eggs of it contain hooks and the mucous membrane of the bladder. So it causes chronic irritation, and chronic infection of schistosomiasis. It will cause that. On the other hand, instrumentation or chronic use of a Foley catheter, and also chronic use the chronic presence of the calculi, stone in the urinary bladder for a long period. It may cause chronic irritation of the mucosa and increase the risk of malignancy. Diet. In general, Mediterranean diet has the lowest urothelial cancer risk due to the increased ingestion of fruits and vegetables, specifically citrus, apples, tomato, and carrots. So, a sedentary lifestyle increases the risk of this bladder, but the Mediterranean lifestyle a little bit because it increases the level of citrus. Genetic changes include activation of the oncogene and loss or inactivation of a tumor suppressor gene. As you know, any tumor have a genetic map or genetic effects in form of active oncogenes and suppressor genes. Two types: suppressor gene and oncogene. Oncogene, it increases the incidence of development, or it leads to development of cancer. But the genes, which is the tumor suppressor gene, it prevents the development of the tumor. So when there is an activation of the oncogene or inactivation or loss of the tumor suppressor gene, it leads to development of a tumor. Loss of the chromosome 9 appear to be consistent finding in all stages grades of CA bladder, suggests early events in a CA bladder development. More recent studies examining P53 tumor suppressor gene mutation in primary recurrent and upper tract tumor suggest that these tumors can have a single clonal origin. Sometimes there is a question come in exam, especially it asks about the genes number, the 9, loss of 9, and loss of the 53 tumor suppressor gene. Put it in your mind, please. Staging. It is very important. Everyone should know the staging of the CA bladder, because the development, because the treatment or management and the prognosis depend on this staging system. So there is the TO, tumor cannot be assisted, CIS, carcinoma in situ, CIS, carcinoma in situ. Okay, CIS, carcinoma in situ. TA, it is within the lamina propria. T1A, T1A, TA, it is the it is the superficial epithelium. T1A, lamina propria. Okay. T2A, superficial muscle layer. T2A, superficial muscle layer. T2B, deep muscle layer. T3, it is the perivesical fat involvement, and it is divided into two types, microscopic and macroscopic. Microscopic and macroscopic. T4, it is the distal metastasis and involvement of the prostate, vagina, uterus, adjacent organ, multiple or different site involvement. What is considered superficial tumor and what is the deep tumor? The superficial, it is the carcinoma in situ, CIS, TA, T1, and T2A. So this have a way for management different from the deep tumor. CIS, T1, TA, T1, T2A only, T2A, but T2P and T3 have actually the very different form of management. Grading system, grade 1, well differentiated, grade 2, moderate, well differentiated, grade 3, poorly differentiated, and grade 4, undifferentiated. Histopathology. 98% of all bladder cancer are epithelial malignancies, with most being transitional cell carcinoma. So what is, question, what is the most common form of the CA bladder? It is the transitional TCC, transitional cell carcinoma, TCC. This common, you will get it. But the most common transitional cell carcinoma. Why? Because the epithelial lining of the urinary system, as I said in the previous lectures, it is the transitional type of epithelium. Okay. Normal urothelium. The normal urothelium is composed of 3 to 5 layers of transitional cell epithelium resting on basement membrane. Beyond the basement membrane is loose connective tissue, the lamina propria, in which occasionally smooth muscle fibers can be identified. These fibers should be distinguished from deeper, more extensive muscle elements. The muscle wall of the bladder is composed of muscle bundles coursing in multiple directions as these converge near the bladder neck. 3 layers can be recognized: inner and outer longitudinal oriented layers and middle circular oriented layers. It is called the detrosal muscle. Papilloma. Papillary tumor with a fine fibrovascular stalk. Papilloma are a rare benign condition, usually occurring in the younger patient. So, one of benign tumor or benign mass involved the bladder, it is the papilloma, but is a very rare. Transitional cell carcinoma. Approximately 90% of all bladder cancer are transitional cell carcinoma. Carcinoma in situ is recognized as a flat anaplastic epithelium. Flat anaplastic epithelium. Non-transitional cell carcinoma, different type of tumor that involve the bladder, but it is known as a transitional cell. Adenocarcinoma. As you know, the adenocarcinoma is more common involve the GIT. Okay? But sometimes there is involvement of the urinary bladder. 2 forms of this. Either it is transmitted from the nearby bowel, or it occurs in patient with persistent urachus. Some during the intrauterine life there is what is called urachus that connect the bladder to the umbilicus. So between the bladder and umbilicus there is a tract called the urachus. It is rudimentary in all people. Some people this rudimentary tract persists and cause adenocarcinoma. So it is a mucus secreting and may have a glandular, colloid, or signaturing pattern. كل هاي الاشياء شايفينها بالGIT. Okay. Squamous cell carcinoma. 5% and 10% of all bladder cancer in the United States, and is often associated with history of chronic infection, bilharzial infection, vesical calculi, or chronic catheter use. It is the most common type in Egypt and causing higher mortality rate in that country. All of it because of bilharzial infection. Undifferentiated carcinoma, rare, accounting less than 4%, have no mature epithelial element, very undifferentiated tumor with a neuroendocrine feature, and small cell carcinoma tend to be aggressive and present with metastasis. Mixed carcinoma, 4 to 6% of all bladder cancer, and are composed of combination of a transitional, glandular, squamous, or undifferentiated pattern. The most common type comparisons the transitional and squamous cell carcinoma. Then the most common present squamous and the transitional, or transitional and the squamous. It is very important. Clinical feature. How the patient come with CA bladder. Hematuria is the presenting symptom in 85 to 9% of patients with CA bladder. Usually intermittent, painless, gross or macroscopic hematuria. Also, patient may come with frequency, urgency, dysuria, may accompany the hematuria. Also, some patients can complain from lots or irritative voiding symptom, more common in patients with carcinoma in situ. Passing clot or necrotic tumor, periurethra, and suprapubic mass. If it is a large neglected patient or neglected himself, may come with suprapubic mass, and also it may cause retention. Sometimes there is a clot retention. Also, it causes palpable mass in the suprapubic region. Sometimes come with obstructive uropathy because accumulation of organized clot, and also distant metastasis may come patient with involvement of other organ by distant metastasis from the bladder. Usually, symptoms of advanced disease include bone pain from bone metastasis or flank pain from retroperitoneal metastasis. Investigation. If patients come to us and complain from a irritative voiding symptom and hematuria, we should start by simple, non-invasive, non-costly investigation. So we will start with urine analysis and send the patient for urine for cytology. Sometimes in some laboratory there is a special kit, something like the dipstick put in urine. It identifies the presence of the abnormal urothelial cell. So by this simple investigation, we can find the or investigate about the CA bladder. Also, sometimes the patient complain from simple symptom. He not feel presence of hematuria because it is microscopic, but complain from recurrent dysuria, frequency, urgency, benign maturation, but in fact he have carcinoma in situ and neglect this condition. Hematology. Almost patient with CA bladder present with anemia due to chronic blood loss or invasion of the bone marrow, increase the blood urea and creatinine. When there is a large mass or large clot that obstruct the bladder, it leads to bilateral hydronephrosis because of the bladder outlet obstruction caused by this tumor or by clot. So it leads to back pressure on kidneys and lead to bilateral hydronephrosis. The patient present and complain from increased urea creatinine, all of it because either involvement of the ureteric orifice by tumor, or it is a large size tumor that obstruct the bladder outlet, or because of the large clot that fill the bladder and cause retention of urine and back pressure on the kidney that lead to renal failure. So it is very important to identify and catch the patient early to do the proper way for management. Radiologically, start by, as I said, simple and available. It is the ultrasound, ultrasonography, The examination of the bladder by ultrasound, very important, the patient in full bladder state, full bladder. There is no benefit from ultrasound examination of the bladder without full bladder, okay? And also by ultrasound, we can identify the bladder wall thickness, the bladder wall involvement by tumor. It is a very important. And then after that, we go for the IVU, following defect in the bladder with or without hydronephrosis. CT and MRI may be used to characterize the extent of the tumor and detect lymph nodes. Cystourethropy and tumor resection. Cystourethropy and tumor resection. It is very important. Any patient do urethroskop for him or cystoscope for him. And by cystoscope, we see the presence of the carcinoma cyto or bladder mass or whatever the defect, and also after that we get a biopsy from it. It is called the TUR biopsy. The TUR biopsy, resection of the tumor by scope, and then sent for histopathology to identify the type of the bladder cancer presence. Now we will go for the management or treatment of the CA bladder. At the beginning of the lecture, I said we have a two type. Either consider this superficial or consider deep. Depend on the involvement of the muscle. If you remember, in the beginning of the lecture, we do the staging system. Depending on the TNM. By TNM, we say the tumor. Either it is TIS, a tumor not assisted, or CIS, a tumor carcinoma in situ, or TA, or T1, or T2A. All of it we can treat it by transurethral resection, followed by intravesical chemotherapy, and then immunotherapy. So, superficial tumor managed by transurethral resection, followed by chemotherapy. What is the type, or what the type of the chemotherapy we use? Depend on the time of surgery. So immediately after we do resection, within 6 hours, we should install the chemotherapy. It is called the mitomycin C. Mitomycin C. For 40 milligram. Mitomycin C. 40 milligram. Within 6 hours post transurethral resection of the TUR. Why give within this period? To prevent the implantation of a new tumor after resection, to prevent the implantation of a tumor cell to the bladder, decrease the risk of implantation of the tumor cell to the bladder. We use the mitomycin C within 6 hours. Some schools say it is enough if we use the mitomycin C within 6 hours, and others traditional way they use the 6 weeks course of the mitomycin. Every week, install mitomycin inside the bladder and leave it for 1 hour, and after that evacuate the bladder. This mitomycin causes sometimes a irritative voiding symptom, but it is very good and very important a treatment for the CA bladder. Sometimes when we find carcinoma in situ, or there is a recurrent tumor after there's a recurrent tumor after the use of 6 course of the mitomycin, we do a second look, put the patient of what is called the interval check scope. The first one after 3 months, and also other one 3 months, and continue 1 year. After that, the second year is the 6 months. Anytime when there is a recurrent tumor, we should do resection of this tumor and go for the immunotherapy. Immunotherapy, as you know, it is the BCG installed inside the bladder. So it should not use at the time of resection. It is 14 days after we do resection, use the installation of the immunotherapy. The second line treatment is the partial cystectomy, and there is an indication for the partial cystectomy. If we have a single tumor within the bladder and have a good distance from the bladder, from the trigone, and good distance from the ureteric orifice, especially when the tumor in the dome of the bladder, we can do resection of the شباب شنو هالصوت؟ Okay. Do partial cystectomy with getting a safe margin. The third one, it is the radical cystectomy. All give the same prognosis, therefore treated by transurethral resection because it has less morbidity and no need for urinary diversion as in cystectomy. So radical cystectomy, it is the removal of bladder and prostate and seminal vesicle in male, and removal of the bladder, vagina, uterus in female, and go for the urinary diversion. And there is a 2 types of urinary diversion. Type 1, it is the orthotopic. What is it called? The orthotopic. So we create or we make a bladder from the small bowel. We get a small bowel piece about 40 cm from the terminal ileum, and then we try to create a bladder. It is called the orthotopic bladder, and it is very important management because the patient return to its normal condition and can urinate and control its bladder. On the other hand, we use the what is called the it is the ileal conduit and the external appliance for urine collection. Radical cystectomy may indicate in superficial tumor if it is. This is the indication. شباب تذكروها مهمة. Indication for radical cystectomy. Indication for radical cystectomy and superficial tumor. أولاً extensive, multiple superficial or large intracavitary tumor, high grade tumor, grade 3 and above, rapidly recurrent tumor after resection or recurrent in high grade, and a tumor amenable to endoscopic resection, the tumor in the anterior wall. Okay, this is the 4 indication for radical cystectomy and superficial tumor. Deep bladder tumor, usually treated by partial or radical cystectomy. Partial cystectomy is indicated in cases in which the tumor is single and located at the dome or fundus of the bladder or at the lateral wall of bladder, which permits resection of 1 to 2 cm of normal tissue. It is called the same margin. How we can do radical cystectomy? Okay, I mentioned it. The most common urinary diversion is ileostomy, when both ureters anastomized to one end of the ileum segment, while the other end exteriorized by ileocutaneous anastomosis. Now, if the patient is not amenable for surgery, he has cardiac problem, he has any medical a problem, we can use what is called the sandwich therapy. It is radio chemotherapy. Radio, it is the second line. If the patient not fit for surgery, we can go for the chemo radiotherapy. Radiation is an alternative to radical cystectomy in patients with, this is the indication, deeply infiltrating bladder cancer, which is beyond surgery. Patients who are poor surgical candidate due to advanced age or significant comorbid medical problems. Treatment generally well tolerated, but unfortunately, local recurrence is common. Also may be used as palliative therapy after radical cystectomy with recurrence or debulking surgery. Okay, this is the radiotherapy. So we have 3 lines. At first, if it is superficial tumor, go for TUR and followed by intravesical chemotherapy. If there is carcinoma in situ or recurrent after chemotherapy, use the immunotherapy, it is the BCG. Sometimes we have a recurrent tumor after that. If recurrence, go for the other option, it is the surgery. Or from the beginning, when we do TUR and we find it deep, it is T2 and more, go for the radical cystectomy. Sometimes we have a partial cystectomy, important by do removal of the bladder mass with safe margin. Also, if the patient have a medical problem, make him unfit for surgery, we can use what is called the chemoradiotherapy. Chemoradiotherapy by giving the patient systemic chemotherapy. It's different from the local. In the beginning of the lecture, I said, or beginning of the treatment, there is a mitomycin C installed inside the bladder. This not cause the complication, non-complication of the chemotherapy, as you know. Falling hair or different type of the complication that occur with radiotherapy, with chemotherapy, but now it is different. It is systemic chemotherapy. Use the cisplatin or different type present that use the systematically for treatment of the CA bladder, and with it the chemotherapy, radiotherapy. So it is called the sandwich therapy. Okay. Thank you very much. If you have anyone have a question, please.
دكتور العفو، الراديو ثيرابي ما نستخدمه بالسوبرفيشال تيومر فقط بالديب؟
بلي طبعا بالديب ثيرابي. هو قلت لك الراديو ثيرابي له two indication. either the patient not fit for surgery or the patient recurrent ومل من الموضوع مال السيرجري. or the patient refuse surgery, refuse radical cystectomy. As you know, a large number of patients refuse cystectomy because of its complication and its hygienic and social problem, as you know. So some patients prefer the use of the second line treatment اللي هو chemo radiotherapy. Okay. Anyone? Anyone, please? Okay. No question? الباحث أخذتوا محاضرة؟